Hello, this is our Day in the Life of series. My name is Dr. Holly Hampy. I am the Program Director and Assistant Professor for the Health Administration Program. And we are very pleased to have Dr. Mary Beth Lang with us today. I'm going to be talking to her about her position as the Vice President of Healthcare Pharmacy and Commercial Services at UPMC. Hello, how are you doing, Dr. Lang?
Good, Dr. Hampy, and thank you for having me as part of this series.
Perfect. Well, what I first want to talk to you about is you're in supply chain and you are a pharmacist. Trying to find out, how did you get to this point in your career?
Well, I started my schooling at the University of Pittsburgh and graduated with a pharmacy degree and worked at UPMC when it was a standalone hospital, UPMC Presbyterian. And throughout my 9 years there, we had 8 mergers, and I was part of the team that would go in and look at how we could optimize services in pharmacy and started to learn more about supply chain and logistics. I left UPMC and went into industry, and I worked for a group purchasing organization for 12 years. And during that time, I went from managing pharmacy and consulting around pharmacy into business development and actually started a company for data analytics around pharmacy and medical surgical. And so I really started to love the business side of pharmacy. About 5 years ago, I was fortunate enough to be recruited back to UPMC. I was brought into supply chain at the time to help them run a business called Prodigo. And from there, we were able to start some projects in pharmacy again, and now I run the pharmacy logistics and part of the pharmacy service line for UPMC.
When you got into pharmacy, were you looking to do supply chain, or what was your initial, when you went to school to be a pharmacist, what were you thinking that your career goal would be?
So I really had no idea what supply chain was at the time. When I started my career, I was looking to practice in hospital. I was specialized as an oncology pharmacist and ran our inpatient oncology pharmacy satellite. And during that time, really started to understand all of the different drug shortages and the impact that not having the right product at the right time could impact patient care. And so I really started to think more about how could we do logistics differently. And that's when I became part and active in supply chain.
Did you work as a staff pharmacist for a while in the beginning?
Absolutely. I started my career as a staff pharmacist. 6 months into that process, I was asked to be a pharmacy manager. And from there, I moved into management and really have been in management ever since.
Before we get into your work, talk about your education. You went to school to be a pharmacist, and what have you done with education since then?
So I was a bachelor's pharmacist. At the time, they did not have the PharmD program, and was encouraged to get my master's by UPMC. And I had 2 choices. I could have gone and gotten my clinical PharmD, or I could have gone and received a master's. And so I chose to go to Carnegie Mellon University and to the Heinz College and get my master's of public policy and management. I really was fascinated by government and regulation and how that impacted the policies that dictated how hospitals ran. And so that's where I started with my master's. And then a few years back, I came to Robert Morris University to get my Doctor of Science in Information Systems and Communications. And really, the goal there, I was running a data analytics company at the time, and I wanted to understand how the entire system of issues came together. And coming to Robert Morris for that program really helped me to look at things in a big picture and really focus on how one component of a system really impact another. And my dissertation topic was how physicians perceived care would change under the Affordable Care Act. And we knew that that act would change how healthcare was delivered pretty dramatically. And so I was able to interview physicians and get their perceptions, and came away with some very, very key learnings that have served me well in the last few years. So I graduated in 2012 from Robert Morris, And most recently, in fact, last month I graduated with a certificate program from Carnegie Mellon. And the goal of that was to look at data analysis and to become more of a data scientist around how big data will be consumed in healthcare.
Now, you said your dissertation was on how physicians are going to be affected by the Affordable Care Act, and the students have been studying about the Affordable Care Act because it is something that's living and breathing right now. If you can give us just a summary of what you have found with your dissertation that you feel, or even with your current work, how the Affordable Care Act is going to change the way healthcare goes in the future.
Sure, thank you, Holly. So when I look at the Affordable Care Act, we're looking more at accountable care. So how do we make sure that not only are physicians accountable, but patients are accountable? So what I learned from my physicians, really five key learnings. One is physicians were fine to give up their autonomy and start to practice more collaboratively with health systems or accountable care organizations if they had a few components of the system available to them. So they were looking to make sure they had a shared culture. And what I mean by that is they really wanted to make sure that their input was taken into consideration. They wanted to have strong leadership. They recognized that they wouldn't necessarily be in that leadership role, but wanted to make sure that the administrators understood the physician's perceptions. They wanted to make sure that there was appropriate care. And so when we think of evidence-based medicine and we think of protocols and pathways, they were looking not only for disease states, but they were also looking to see how they use technology and imaging more in a evidence-based fashion, so that appropriate care could include ways to not have to provide care. So if we did a lot more preventative maintenance and preventative care, diagnostics to look at chronic care earlier, they could have earlier interventions. Those were components. They also were thinking of accountability. When they wanted to practice, they want to be able to practice at the top of their license. And so for them, they were looking at care extenders. So looking at how do they expand the care coordination. And what we're seeing is that that in fact is already happening. So when you think of the care team today, the majority of resources are in the acute care setting. The care tomorrow will include many new caregivers that don't even exist today. And so at UPMC in the last 2 years, we've added 35 new positions to the care team, positions that didn't exist. And different things such as concierge medicine, having pharmacists involved after discharge and in clinics, being able to do more care at the patient's home than we do at any other site. The other component for the physicians, the last component, was accountability of the patient. And what we have found is we're treating patients for lifestyle and behaviors that have detracted from their health. And the physicians want to make sure, excuse me, when they think of quality and when they're judged on quality, that the patient's lifestyle is factored into that quality equation. Mm-hmm. And so if you have a patient that has smoked 2 or 3 packs of cigarettes a day for 20 years, they don't exercise, they don't eat well, if they present to a hospital and coronary disease or any other related issue of diabetes, that if the patient has a bad event, that can't just be the physician's quality taken into consideration. So those are the key things that I learned, and it makes a lot of sense. I think that the Americans, that when we look at population health management, 50% of our population will never seek care. And that 50% that does seek care, they want an e-visit. They want to be able to go to a retail clinic, something that is very convenient for care. That 50% will likely never have a primary care physician. Very, very different in a model that we don't have that exists today. My daughter just finished her freshman year in college, and when I brought her to North Carolina. I gave her a Fitbit, an iPhone, and the UPMC Anywhere Care app. And she was able in her first year to go onto that website, answer a few questions, and she had a sinus infection and another small little ailment. We had connected her to a pharmacy that was a mile away from campus. The pharmacy was able to fill their prescription and deliver it to campus. She never saw a physician, she never went to the pharmacy, and she was able to get her prescription. Very, very different healthcare today than what we'll see, or than what we have today.
You know, a lot more telemedicine, a lot more physicians.
Absolutely, absolutely.
Making the patient accountable for their care is a different, taking the pendulum to the other side, and the patients need to be part of it.
Absolutely. We have a whole generation of Americans that are getting ready to retire, the baby boomers, and many of them think of healthcare as a $20 copay or a $50 copay. They really don't understand the entire cost of healthcare. We've gone from a very small copay to where now Americans have 20% of healthcare expense as their responsibility. And so when we think of healthcare today, it's under, many Americans have through their work a defined benefit of healthcare. They expect that that's part of what they will receive as their employment. In the very near future, we'll have a defined contribution. So organizations, companies will move to a defined contribution, and what I mean by that is they will dedicate a certain dollar amount to healthcare, and that's all that they will pay of healthcare, and the American will have to pay the rest. And we did see this years ago with retirement. So we moved from having a pension that was guaranteed to a 401k position, to where the company would agree to pay a certain percentage or match a certain amount, and that has become a defined benefit. At the time, it took 7 years for companies to think of moving from a defined benefit to, or a benefit to a defined contribution, and the experts now think if we did that in healthcare, it would take 2 or 3 years. So we would see a rapid movement. And that's really what's changing, and we're seeing that with the healthcare exchanges. So healthcare is really moving from business to business decision, where your organization decides on a health plan, and as an employee you can sign up to that health plan. Under the healthcare exchange, what we're going to see is that each consumer, each American, will be able to pick their own health plan. So design their own health plan based on their physicians, based on any disease states or any other circumstance that they need to consider, and then really design their own plan. So it will move quickly to a business to consumer environment.
Customization.
Absolutely.
Before we talk about your position at UPMC, you talked about being part of a data analytics.
Mm-hmm.
And you know, if you look at the positions that are available in healthcare, there's a lot about healthcare analytics. Can you give us a little bit of an idea of, you know, how you got into that position, and what did you learn from that position? Sure.
So when I was in industry, I was asked to start a data analytics company. And I started with a business plan and a thought around, I was in a group purchasing organization, so my data focus at the time was around purchasing. How could we help hospitals save as much money as possible by taking advantage of the contracts that were available to them? So if you think of supplies, supplies are the second largest expense for any healthcare organization, or any organization really in any industry, behind labor. And so I was asked to create several marketable products that would look at data analytics around purchasing. So I looked at price accuracy based on a contracted price, utilization and optimizing products based on what could be used in a hospital, and also based on physician referral patterns. Where were physicians practicing? What was the cost of practice per procedure? And so that's really where I started my career in data analytics. When I've been back at UPMC, I've been part of the data governance process for UPMC, and we have a very formal process for looking at big data, looking at how we can, under a cost management approach, how we can determine the cost per procedure, how we can determine, my focus is on pharmacy, and if you think of a pharmaceutical, we have every pharmaceutical that's in the UPMC formulary, and that's the list of products that are available and are approved to be used at UPMC. We make sure that we track those products for every single application that we have at UPMC. So in pharmacy, we have 200 applications that have an NDC, or it has a pharmaceutical footprint. And so I'm responsible to make sure we understand how those drugs are represented in every application, and to try to connect the dots around utilization. And so that's really where my focus has been. It's been very, very rewarding. What we have found is we're able to look at our cost quality profiles and try to reduce inappropriate use of those medications, at the same time as helping us to properly represent every data element of pharmaceuticals in our 200 applications.
Now, talking about your current position at UPMC and talking about what you're evaluating, what information gets back to the physician regarding the appropriate use of pharmaceuticals? Is that something that is part of that analytics?
Absolutely. So what we have done is we have partnered with the Chief Medical Officer at UPMC and with our cost management team, and we look at the appropriate use of pharmaceuticals as well as all supply chain items, and we're able to help physicians. And so part of what we've seen in the sea change of moving from volume to value, which was the tenet of the Affordable Care Act, is when you no longer get paid based on seeing more and more patients, the change to value has been very impactful at UPMC, and I would say across the country. And what we're finding is physicians now want to look for ways to reduce their cost profile. And so we convene many interdisciplinary groups to look at utilization from many different lenses. And so when we think of utilization, we want to make sure that we look at cost per procedure, that we look with physicians on ways that their peers might be using products differently with the same outcome but at a lower cost profile. We have found that physicians now are incented. This is the first time that physicians have really had a performance appraisal. If you think about it, most physicians were paid based on seeing more patients, and now under this new era, they're paid based on doing the right thing, doing appropriate care, and we've seen a big change at UPMC, and I've heard that across the country as well.
And my experience when I was in the hospital, talking to physicians regarding their practice patterns and comparing them to other physicians, sometimes met with some resistance, that the data was not, their patients are sicker, the data wasn't correct. How do you get around that part of it?
We have found that our Chief Medical Officer has really set the tone for the organization to work differently. Every time that we can save $1 in supply expense, we really can protect another job. We can protect a nurse, we can protect a pharmacist. And physicians are really realizing, based on their cost quality outcome profile, that some of these small decisions could make a big impact. The other big change for us is we had 125 physicians that were not re-credentialed. They were not invited back to practice at UPMC because their cost quality outcome results were too high. And that really set a different tone. Mm-hmm. When your Chief Quality Officer says, we can no longer support your clinical service because you're too expensive, other physicians take notice. Mm-hmm. Other clinicians take notice. And so it creates a different collaboration, it resets our culture around doing the right thing, around preventing care as much as possible. And that doesn't mean that we won't produce a quality outcome. Quality is really the first layer of our decision. And if we can get to a quality outcome, the physicians are now more willing to look at evidence-based protocols. The other big thing for us is we've taken the word preference out of our culture. And so it used to be that physician preference was used a lot in the OR, whether they had a suture or whether they had a certain device. We would look at, Dr. Smith, this is his preferred agent, this is his preferred device. And now we talk more about procedure cards. So based on UPMC, based on our clinical review of the procedure, we have a certain recipe or we have a certain list of products and protocols that are appropriate for that procedure. And there isn't a physician preference. That's part of it. And that's been a big, big culture change for us, Holly.
Yeah, to have not re-credentialed a physician really says that you are standing behind what you say. And I think that's probably the first I've heard of not re-credentialing based on quality and outcomes, and that's, I applaud UPMC for doing that. Your current position, can you describe it, and can you tell us how you fit into the hierarchy
Sure.
of UPMC, and what type of people report to you?
So my current position, I'm the Vice President of Healthcare Pharmacy Central Incorporated. And what that is that's a local group purchasing organization and self-distribution for pharmaceuticals. This organization was developed or started in 1979, and it predated a lot of the national group purchase organization structure. And at the time, 15 small independent hospitals came together to try to leverage their pharmaceutical spend to get better pricing. And over time, 12 of the 15 entities later became the part of UPMC. And so they started their work in working collaboratively in the pharmacy area. The chief financial officers of every hospital and the directors of pharmacy would meet on a regular basis and really look at ways to reduce the cost of pharmaceuticals. And over time, since the 70s, we have grown in responsibility. We now support 25 hospitals. 5 of those are for facilities outside of UPMC, and the remaining hospitals are UPMC-owned facilities. And we provide a service. We provide everything from all of the contracting that goes on for pharmaceuticals. We pay all of the bills. We manage all of the discounts that you could get through the process. And in that structure, we are able to provide value back to all of those entities in millions of dollars. So it's a very, very successful model, and it really has stood the test of time because we have been very creative and innovative over the last 4 or 5 years to make sure we're maximizing discounts and trying to reduce the cost of pharmaceuticals. And for those that don't know, pharmacy represents 23% of all of the supplies. So at UPMC, we have probably about $3 billion in supplies. When you think of any product or service that could be used at a health system, for pharmacy, we represent about $700 million in pharmaceutical spends a year. So significant footprint. I report to the Chief Supply Chain Officer directly, but indirectly, I report to the Vice President of Operations for the UPMC Presbyterian Shadyside campus. The VP of Ops, which we call him, is my board chair for HC Pharmacy. And I also report to our health system Chief Financial Officer, who is the pharmacy service line leader. And so I have 3 bosses, but under this environment, it's a very matrixed management environment. And so you have to learn to be a good follower of multiple executives, a leader in the pharmacy service line logistics, which is what I've been asked to lead. and a peer to all of the directors of pharmacy that still provide the services that we offer at every single institution. Not only do I run the distribution services and contracting and such, I also have been asked to support inventory management at every hospital. So although I don't have resources that report directly to me, they report to me through a matrix environment. And the goal there is to just have enough inventory on hand to serve our patients and not have excess. And so that has been, it's been a struggle, but a good challenge at the same time.
One of the discussion questions that the students had discussed last week was whether hospitals should continue with an inventory, and if you can get away from having an inventory because of the cost of keeping something on site. How do you get a balance of just enough supplies to serve the patients? And you touched on it a little bit. Can you touch on a little more as far as how do you keep that balance? As particularly, in the event that you had an epidemic or had an emergency, how do you get those supplies in to a facility such as UPMC Presby?
Sure. So it is a balance. Inventory cost are a significant cost, and pharmaceuticals are very expensive. And when you think of pharmaceuticals compared to a med-surg cost, we might have $40 million in inventory in our warehouse for pharmacy. We might only have $13 million for our warehouse for medical surgical. And if you look at the warehouse sizes, they're 3 times larger than we are, Holly. So their cost is so much less, but the number and the different types of products they need to support is more. For on-site pharmacies, our model affords them the ability to only store 3 days worth of product. We have found with peers across the country, because of drug shortages, they're stocking as much as 30, 45 days of product on hand, and it's a balance. In pharmacy, we have 1,000 different drug shortages every week, 1,000. And to manage that, we have to have 3,500 alternatives that we source and we have on our watch list. And so because we're doing a lot of the heavy lifting about shortage management, we're able to bring in larger supplies to our warehouse and have that on hand and then allocate that out to the hospitals. And for all of the customers that work with us and the hospitals that work with us, they don't need to have that on-hand amount. They don't need to hoard and worry that they won't have that drug available to them because of our model. But inventory management is a balance, and chief financial officers are always looking to have its least of product and reduce their cost footprint as much as possible. And so we found the good balance of having it in our warehouse, one place, and then 25 hospitals, 300 clinics, and 700 physician offices are able to pull from our supply.
Where is your warehouse?
So our warehouse is on the south side of Pittsburgh, which is centrally located for 8 of our facilities. We're 2 hours away from Hammett, which is, UPMC Hammett is 2 hours north, and UPMC Altoona is 3 hours west. But the remainder of our facilities are usually within a 30-minute drive. So it's as centrally located as we can with our ever expanding footprint of UPMC.
So UPMC Hammett, if they needed a medication and it was something that was in the warehouse, it would be something that would be shipped to them?
Sure. So
couriered?
We have 5 days delivery to all of our facilities, Monday through Friday. We have the ability to do stat delivery, and we have the ability to do an overnight FedEx or UPS delivery as well. So many options to be able to get the drugs to our different facilities. Traditionally, on the rest of the industry, they're getting 5 days a week delivery as well, Monday through Friday, once a day, usually in the morning. so that we follow that same process.
What happens in an emergency? Is there stockpile someplace?
So we work very closely with the state and with the federal, with the CDC, and we have, we're the regional emergency stockpile, and we have what they call chemical packs, that we have all of the medications that you would need for an epidemic, and we're able to keep track of that, and we have disaster recovery plans, as well as many other processes that we have in place to handle a disaster or handle an epidemic.
So how do you track all of this volume? You know, I'm sure that you've got computer systems and barcoding and scanning systems to tell you exactly what you have in stock.
So a few different ways. We have an enterprise resource planning tool called Oracle, and we're able to keep track of all of the medications that are used anywhere in our system. We also have a warehouse management solution, and that system is able to barcode scan every single product that comes in or is picked to go to one of our facilities. And what we have done most recently is we have to comply with the Drug Supply Chain Security Act, which is a new act that was passed in November, and we will be required, as every hospital will be, come July 1st, to be able to track key information throughout the supply chain. So when you think of counterfeit drugs and you think of being able to have a pedigree, serialization pedigree, look at a product from the time it was first manufactured till the time it gets administered to a patient, that's a new regulation that we're complying with, and we've added components to our warehouse management solution to be able to do that. And it's important. It's important that every product that we use throughout our entire supply chain can be traced back to the original time it was manufactured.
What type of projects are you working on, and what would a typical day be like for you?
Well, unfortunately,
If
I don't
there's a
have a
typical
typical day. So I'm working on many different projects. So I mentioned the Drug Supply Chain Security Act is a big project. We do that locally, but we also link into national groups. I'm involved in the National Healthcare Supply Chain Group, and actually the chair-elect of that group, and the acronym is ARM, the American Hospital Resource Materials Management Group, and I learn a lot from that because I wasn't originally in supply chain. I joined that association, and once I graduated from my doctoral program, I really wanted to give back to industry and become involved, and this was a great organization. And with that supply chain group, I work on several projects. One project is we're trying to link healthcare providers to students through supply chain programs and offer summer internships. And so this year, UPMC has grown our summer internship program. We call it our summer associate program, and we now have 11 summer associates. Two of them are working with pharmacy, and the other 9 are working throughout other areas of supply chain. So that's a big project. We're trying to link more and more providers with students to give students the ability to work within a supply chain and still get paid, because that's important for us to make sure it's a paid internship. The other projects that I'm working on really would be consulting. We have many health systems from across the world that come to UPMC to see how we do supply chain management. So my latest project is I'm actually going to the Middle East on Friday, and we're consulting around a hospital, Sidra, and they're looking to open their hospital and their outpatient clinic, and they want to make sure that they're ready. And so we're bringing a team of consultants, I'm the project manager, and we're going to do a full assessment of supply chain and make sure that all of their procedures are in line with what we recommend, and if we find any gaps, we'll be able to provide them with a report of how to remediate those gaps. So that's an example. This was one visit that they came to see our supply chain, and then now they're inviting us to go to Qatar to make sure that based on their country and their regulations and the requirements, that they can open their facility on time.
Being it is not part of the United States, is there anything that's of concern that would be different that you
Oh.
have to take into consideration?
Very, very different supply chain. So luckily UPMC has managed in other countries before. We had a hospital in Ireland that we managed. We manage today a hospital in Italy, a cancer center that we opened in Italy. We've looked at different supply chains in Kazakhstan and other countries. And so that's one thing you have to look very closely at, Holly. You have to see what are the requirements, what are the regulations, what are the custom concerns. I was able to go to Dubai last month and work with the Gulf Collaborative Council, and they are all the Arab nations that come together around supply chain, and learn firsthand from them, from Saudi Arabia, from the United Arab Emirates, exactly what they do to overcome some of the supply chain issues. And it's very fascinating. We have products here that we've had out and have been released by our government for 2 years. And I heard at the conference that one of the governments has just released that product and for use in their country. And so availability is an issue. Some of the countries have problems with customs. So sometimes they'll be able to get a chemotherapy agent into their country. They start a patient on that product, and then when they go to import it through customs again, it's rejected. And so they have to deal with, do they have enough product to manage through an entire course of therapy? So very, very different supply chain logistic issues than what we have here in the States. But some of them are the same. You know, getting the right patient or the right product to the right patient at the right time is a universal issue. And so how they have their system set up, how they have their products set up, those are things that we'll pay close attention to.
If someone were to ask you, what does supply chain management mean, how would you describe it?
So for me, supply chain would be any non-labor expense would be part of supply chain. The logistics of supply chain would be the activity of moving products from the first time you contract that agent all the way through when it is administered to the patient. So the entire supply chain management is very comprehensive, trying to make sure that you think through all of the different logistics, that you think through the lead time it takes from the time you order something until it's delivered, and managing the financial component of the non-labor expense. So understanding contracting and any discounts that go with healthcare, and it's regulated, very heavily regulated by the government, to understand how you determine what products can be used in your facility. In pharmacy, we do that through a group called the Pharmacy and Therapeutics Committee. That committee is based on the Joint Commission oversight and the rules that they put in, the compliance and criteria they put into effect. On the supply chain side or the materials management side, that committee is called Value Analysis. And Value Analysis is usually a multidisciplinary team that looks at, first, should they use that product in their facility, and then the appropriate use of that product. So those are all the components that I see in supply chain management. And you're partnering with your chief quality officer, with infectious control, with your finance team, as well as your physicians and your clinicians, to make sure that they have what they need to practice.
What about the frontline person? How would they see a supply chain? Would they understand that?
It depends. So at UPMC, most of our frontline people for non-pharmacy see supply chain through an electronic marketplace. So they're able to sign into through our regular systems and see an Amazon-like shopping environment. And through that process, they can access a little over 1 million different items from our marketplace. And so for the end user today, it's a much easier experience than when I started practicing and you filled out a paper requisition and you hoped that it would get to somebody and somebody would respond. Within 2 or 3 clicks, clinicians now can go in, order what they need, and get back to clinical practice. So very different way to look at supply chain at UPMC than it was in the 80s or 90s.
As far as your position, what is it that you like about what you're doing?
Well, I have to say, I think my position takes all of my past experience into consideration, and I think I use every skill set that I've honed over the years. You know, certainly my pharmacy and being able to practice in a pharmacy, I think of that every time that we have to make a contract decision, every time we have to look at a change in our products, looking at data analytics and all the work that I've done before. I mentioned the work that I do with our data governance team, and running a startup company. When I was in my group purchasing organization, I had to learn all the business acumen that went with a startup company. Running the for-profit entity of UPMC, of HC Pharmacy, really takes me back to making sure that we're making sound business decisions, working with a board of directors that report into a higher level executive team, and all the work that we do internally with the executives that we work with, as well as working out with other peers in the industry and with vendors, all the negotiation that I need to do on a daily basis. So yeah, I love the fact that I can take all of my different disparate experience and it culminates into every day of what I do.
It does seem like you have been able to build up to the point that you're at now. Looking back, and these are students that are just looking forward to a career in health administration, you know, when you look back, how did you strategically plan that? Was it something that you did consciously, or was it something that you did unconsciously?
Through serendipity, maybe. So some of it was really taking advantage of opportunities. So my biggest advice to students is really to network. When you think of networking today, it's not simple of joining into LinkedIn and trying to get as many people to connect. Really making your connection relevant and making sure that you have the ability to learn. Pick very different mentors and pick them for different reasons. So when I looked at my career, I was able to, as I mentioned, become a pharmacy manager within 6 months. And the way that I did that is there was an evening position, an evening manager position that was open, and nobody wanted it because it was the evening shift. And I thought about it and said, well, this is a great opportunity for me to learn management. And so I applied. And crazy enough, I was promoted. So taking advantage of opportunities. When I did my master's work at CMU, I had a professor, Dr. Ian Rawson, that I went back to him after our capstone course and said, would you ever think of having someone else team teach this with you? I would just love to help you. And I started to teach that class and taught the class for 3 years with Dr. Rawson, and it really exposed me to many things. It exposed me to, you know, the teaching side of healthcare. I taught that capstone course as well as an introduction to healthcare at CMU, but it also gave me my next job. So Dr. Rawson had just moved to a new position and then invited me to apply for a pharmacy consultant position. I never dreamed of leaving hospital and going into industry, but it seemed like a really good opportunity, and that opportunity led to many other opportunities. And don't be afraid to take a position because you want to learn new skills. I made several changes in my career because I wanted to learn new skills. It wasn't for a larger title, and sometimes it wasn't for more money. I've even taken positions where I've taken a step back in money and taken a step back in title because I needed to change my environment.
Mm-hmm.
When I was doing my doctoral work, I wanted to be closer and back at a provider. I wanted to be closer to physicians. And so I went from being the president of an organization at a certain salary and came back and I was a senior director. And at the time, people thought I was crazy, and I probably was, but I wanted to be back in an environment where I would be closer to the physicians that I knew I needed to interview. And at the time, I was in a very large role, traveling every week, at least 3 or 4 days a week, away from my family, and being able to make a life change because it was a better work-life balance was important. And so don't make decisions just based on what career opportunities, but try to balance them with your family life as well. And coming back to UPMC, I started as senior director, and literally the day after I defended my dissertation, my boss promoted me to vice president. So there was a lot of value in the education. There was a lot of value in the learning that I had from doing all of my research, and I was able to apply that, and it was recognized. So also I would encourage you to look for positions where you really have a great connection with your boss. Don't stay in an environment that's not positive, and try to look for other opportunities. And sometimes that means taking a lateral position because you know that you can learn from a leader that might be in a different area of your organization or in other organizations. And the other thing is, if you have the opportunity to network and to become active in associations for your profession, do that. You know, I mentioned my work with the supply chain organization ARM. I've met very, very accomplished critical thinkers and leaders of supply chain across the country and the world, and I've been able to have great dialogues and learn a lot from them. And so those are some of the lessons that I've learned that I would share.
And I look back on one of my entry-level positions into administration, and the same people are still at that organization, and this is 20 years later. And, you know, as you said, don't be afraid to make a change. You know, some people get so caught up in that, you know, I know this job, I'm gonna stay in this job until I retire because I don't wanna make a change. And we've talked about what you enjoyed about your position. Is there something that you don't like about the position?
I think the hardest thing is I just don't have enough hours in the day or the week. So I am blessed with having a very capable staff. And so when I started my position back at UPMC, my boss told me 3 things. I didn't have staff reporting to me, I didn't have to travel, and I wouldn't be in sales. And all 3 things have turned out to be not so much true. But I do have staff today, and I have 45 staff members in my division. I have been able to take a division that wasn't as progressive and upgrade the talent. And so I've been able to, every time I have an open position, look for gaps that we have in talent and be able to re-engineer our job description so that I can go and seek the right talent. So as I've looked at building a staff, I look at our deficits. I make sure that you know, I tend to practice in the global thinking layer. And so I know I need to surround myself with good, detail-oriented colleagues. And so being able to fill my deficits has been very important throughout my career. So I would say if I could change one thing, you know, I'd love to slow down the change of healthcare. And
See if you can do that.
we don't have that luxury, but being able to constantly think of what is the next big change that's going to hit us, and are we prepared, and how do we become more prepared is probably my largest challenge today.
And as I've said to the students, change is the only thing certain in healthcare today. And, you know, you've got to be an agent of change in order to stay up with it. Looking back on your career, the position that you're in and the positions that you've had, what would you say your greatest accomplishments have been?
Well, I think a few things. I mentioned the data analytics company I started. I really started that company at a time when the organization I was with wasn't ready for change. They weren't ready for innovation. And I was able to, through a small subgroup, incubate an idea through a business plan that later became just a large footprint of that organization When I left, we had 9 different products. We were in hospitals that represented 6 out of $7 billion in our company's customer base, so significant footprint. I would say that's been a success. I think my current responsibility at UPMC, I think I'm most proud of the fact that I've taken a very manual supply chain and I've brought it into this best practice environment. So we've been able to move our transactions to electronic, to where we don't require staff intervention. We've been able to really take the technology and utilize it fully, and that wasn't available when I first started to manage this environment. The other component, I think, is really in staff development. I think it's very important to prepare every staff member for the next position. And so I spend a lot of time in mentoring, a lot of time with students and with staff that's getting them ready for their next position. It's important to me to share with students the fact that you never know who your next boss is. And so how you conduct yourself, how you work with leaders, whether you agree with their thought process or not, they're in that position for a reason. You never know if at one point in time they might be your boss or you might be their boss. And so, the caring and the listening and the integrity and your behaviors are very important. I joke with some of our newer staff members and when we think of what to wear and, simple things, I encourage students, don't dress for the job that you have, dress for the job that you want. And it's not just a dress, it's behaviors. Get yourself onto projects, get yourself noticed, become the guru of Excel or other technologies that you can contribute differently than what your job title is or your job description states. Become indispensable, and that will afford you many, many opportunities beyond just waiting for the next job opening.
Good advice. What would you change in your career? Anything that you look at and you say, in hindsight, I should have done this differently? Or
Well, I think a few things. One is, I spent a lot of time on the road. So when I look back, my son graduates tonight from high school, and he'll actually be at the Soul Center with his classmates, and he's my second to graduate high school, and I have a 13-year-old. So, the balance of trying to be home and be at every event and have a career is always a challenge. And so would I want more time back? Sure. But as far as decisions that I've made, I've just made it a point not to regret a decision, but to capitalize and to really structure it and make the best of all situations. You're never going to be in the ideal situation. There'll always be something else that you want or need. And the other component for me was to make sure that all of my business interactions were conducted in a manner that I could be proud of. Mm-hmm. And make sure that you look long-term when you make a decision and not just what makes sense for the current.
Now, you talked about students and people that you have working for you. These students are going to be out in the work world soon, hopefully in a health administration position. If you were interviewing someone, what characteristics would you be looking for in an individual, and what type of individual would meet your qualifications on an appropriate candidate for a position?
So I guess I'm fortunate because I have several students that come through our area regularly. So in addition to the summer associates in supply chain, I work with the School of Pharmacy at Pitt, and I am able to host many students that come through. And I have to say, I can tell in the first week if this is a student that I'd want to hire or if this is a student that will not. We'll go through the rotation and they'll go on. The students that I want to hire have similar qualities. One, when they come to work, they're very prepared. They've done their research. They know a lot about the leaders in our area. We have LinkedIn. You can learn a lot about professionals through that environment. They've researched the organization. They understand UPMC. They know what our mission is. They know what our values are. Not that they recite them, but they just understand what business we're in. And then they're very, very engaging. Students that come and they're looking to learn more. They're looking to make sure that they're doing all that they can do. They're self-motivated. They have a very professional demeanor about them, and they're well-spoken. They're well. Their communication, written communication, is strong. Those are the students that catch my eye. In an interview perspective, students that can give good examples of past events through a behavioral interview process, that understand that they shouldn't give the same example for every response, that they have a good variety, well-rounded students that have, many of our students have traveled, they've done semesters abroad, they're involved in philanthropies. Those are students that we know can handle the work-family balance. And some students that work for us while going to school, that understand that they've made a commitment and they can meet their work commitments as well as their school commitments. Not that you can't change your schedule, but if you're constantly calling off, they likely wouldn't be a student we hire out of school. I will say that our first student that I have from Pitt that did a rotation with us just started this week and is a full-time pharmacist for me for sourcing. Very non-traditional job out of pharmacy school, but he loved the rotation and we loved him, and it's a great match and a great story that we really try to hire students that have worked with us, and students that aren't afraid to ask for references, and many times even when you've done your rotation, if you've connected well with the leader, stay in touch with that leader. Send them an email every so often, let them know what you're doing, just stay on their radar. And when you're ready for a reference or you're ready for another job, now you have a network.
Yeah. Networking is so important.
It really is.
And final, what would you like to say to our students in wrapping up this about the supply chain, about your career, about advice? Any final thoughts?
Just that this is a great time to be in healthcare. It's a scary time, but it's a great time. And in many aspects of healthcare, what I love about healthcare is it's really opening up. There are many disruptive innovations that are starting to be introduced into our environment. So when you think of healthcare administration, don't limit yourself to a health system or a hospital. Many non-traditional companies, think of what Walmart's doing, think of what Amazon's doing, Apple, they're all getting into healthcare. They will be disruptors in the very near future. When you think of Walmart, they want to be the leader of primary care, and they're well on their way. I just connected with them last week, and their vision is to own primary care for healthcare. When you think of Walgreens wants to have their clinics, but they say they will be doing surgeries in their clinic in 8 years. Things that we never thought would happen are now happening. With Apple, they're doing a lot with their health kit. They'll change the way that research participants are recruited. They'll change the way that we look at health in the future. Amazon met with the FDA in the last couple months, and they have a phenomenal marketplace that they have a significant customer base today. We kind of joke and say, at some point they might be sourcing all of our hips and knees, and you bring your device into the hospital with you when you come to do your surgery. Joking at that, but I think Amazon will have a footprint in healthcare. So don't limit yourself just to traditional healthcare, because it's changing.
I remember in the mid-'80s when DRGs came into existence, and I was working for a company, an insurance company, and we were talking about doing surgery on an outpatient basis, and I can remember a New York physician saying, we'll never do surgery on an outpatient basis. for doing surgery on an outpatient basis.
Absolutely.
Thank you very much for coming today, Dr. Lang, and I'm sure the students will appreciate the information that you have provided, and you know, it's always good to have an RMU alum come back and share what the success of their career is, and we thank you very much.
Thank you, Holly, and best of luck.